back, ladies and gentlemen, to ADHER-ENT First and 15. Today is my pleasure to have our guest, Professor Jannis Constantinidis, which is the actual president of the European Rhinologic Society. Good morning, Jannis.
Good morning, everybody. And thank you very much for your invitation. I very much appreciate your work that you do to bring us all together in different places in the world. And I will send all my best wishes to all our friends, all the Rhinologic family, let's say. So I would like to talk about approaches to the frontal sinus. And first, I would like to give you a few historic information. So if you go back to the past and you see the literature, you will see that the first described procedure in frontal sinus surgery was a trephination described in 1750. Then it was a time between 1870 up to 1920. All the famous rhinologists, all the famous frontal sinus surgeons and rhinologists and sinus surgeons have used parallel endonasal and also external approaches. But you know, this was a time without antibiotics, and this was a time without CT scan. That means the surgeon has not the ability and was not able to see the individual anatomy preoperatively, and therefore all the surgeons that used an endonasal approach had a higher risk of complications, and many patients died, and therefore the majority of them switched to an external approach. And then this was a time between 1920 and 1970. This time was the domain of external procedures, described from Janssen Ritter in the German literature, Lynch in the United States, and Howard in the UK. And then there was a time in the beginning of 1970, and this was a very important time because a renaissance of endonasal and frontal sinus surgery starts due to the use of the microscope and endoscope, the improvement of the anesthesiological procedures, the better understanding, of course, of the pathophysiology. Don't forget here the experimental work from Messerklinger and also from Heinz Stamberger. And then don't forget also the use of CT in our daily life, because CT means we are able to see the individual anatomy preoperatively. We are able to see the extension of the pathology and the relation of the pathology with the advanced anatomical structures. So we are coming to our days, but the major goals are the same. So we have to restore the drainage and the ventilation via the natural ostium. We should remove the sinus pathology and think also about to restore the natural anatomy of the bony walls, especially if the anterior frontal sinus wall is missed. We have to think to reconstruct the anterior frontal sinus wall. I would like to start with my first teacher, Professor Draff. He was one of the pioneers in endoscopic and microscopic sinus surgery, and he has classified the approaches to the frontal sinus into 3 types. I was with him, I was residence with him. He was a great teacher, a great personality, and my talk is dedicated to him. We should never forget also our teachers. And you see here, this is an endoscopic view. This is a view from the surgeon. You see that the type 1, we perform a complete ethmoidectomy and we expose the ostium of the frontal sinus. You see the black line is the middle turbinate. Here is the medial. The red line here is the medial orbital wall. And here the yellow fibers, these are the first olfactory fibers. So type 1 means complete exposure of the frontal sinus ostium after an ethmoidectomy. Type 2A means we remove the frontal sinus floor from the middle turbinate up to the medial wall of the frontal sinus. And in a type 2B, we extend our drainage, our removal of the frontal sinus floor up to the septum. And type 3 means 2 type 2B drainage, one of the left, one of the right side, with an additional removal of the perpendicular plate and the interfrontal septum. Of course, the type 1 drainage is our workhorse. This is a chronic frontal sinusitis with polyposis. We have performed here a middle meatal antrostomy, and then you see we perform an ethmoidectomy. I always start from posterior because the ethmoidal cavity is wider in the posterior area, in the posterior part of the ethmoids, and then I use a curved curette and remove all the pathology. You see it nice up coming to the frontal recess here, this area. And then you remove here also the anterior ethmoidal cells, and you expose nicely the frontal sinus ostium. This is our workhorse. In the majority of the primary operations, we expose and we perform a type 1 drainage. You see it here nicely again, the ethmoidal cavity, medial orbital wall, and the frontal sinus ostium. This is a type 1 drainage. What are the failures and what are the causes for failure in endoscopic frontal sinusotomy, and especially also in type 1 drainage? Please don't forget these 4 causes: incomplete removal of anterior ethmoidal and Aganasi cells, the lateralization of the middle turbinate, suprabulla and supraagar frontal cells, and an osteitis and osteomyelitis. And I will give you an example that makes more clear all these causes. You see, this patient had 2 years before a primary surgery, a previous frontal sinusotomy, and you see the anterior Aganasi here in the anterior part, and Aganasi cell was not removed, and you see that the middle turbinate is fixed on the lateral wall, and this has completely obstructed the drainage and the ventilation of the frontal sinus. This patient has headache and has multiple recurrent frontal sinusitis. And here we have to remove here this anterior this anterior ethmoidal cell. You see it here nicely, here with a curette. And then you have to evaluate the stability of the middle turbinate. If you have the feeling that the middle turbinate is not stable enough, you have to fix it on the septum. And you will see it here exactly. You see here very nicely the ostium, the frontal sinus ostium. This is the ethmoidal roof. And then we evaluate the stability of the middle turbinate. I'm using personally sutures to fix here this middle turbinate on the septum. And you have to think about that after many months and after years, there is a tendency in an unstable middle turbinate to lateralize and to obstruct here this area. Therefore, I have here fixed my middle turbinate, and this is the final situation. Another problem are anterior ethmoidal cells extending into the frontal sinus, the so-called supraagar frontal cells and the suprabullar frontal cells. And here we have to be very careful to remove also these shields. And you see, what are the indications in a type 2A? You see acute rhinosinusitis with complications, chronic rhinosinusitis, mycopioceal, small benign tumors, and trauma. And I will give you an example. This is a case with a very narrow frontal sinus, especially here in the anterior part, and then a supraagar Nasi frontal cell. You see that this obstructed the frontal sinus. In this case, I have also performed an ethmoidectomy, and coming from posterior to anterior, you see here the bone is very thick. You see here in the CT, and therefore there was a need to use also a curved burr to enlarge here the drainage to remove the floor of the frontal sinus. And you see that we enlarge step by step this drainage, and the pus is coming out here. You will see it. And then you can use also a navigation system if the area is very narrow and if you are not sure. This is very helpful. And here the problem was this agar-Nazi cell extending into the frontal sinus. So we have removed it, and then you can go and enlarge also a little bit more, and you will have in the end have a very nice frontal sinus drainage. So in a type 2B, you see that means an extension of the drainage up to the septum. You see that the indications are nearly the same. It depends on the individual anatomy. If you have the feeling that your drainage is not enough, then you can extend a little bit more medial and perform a type 2B drainage. I will give you an example. This is a patient with an inverted papilloma. I have removed here the inverted papilloma, and you see I'm step by step approaching here the frontal sinus. This is the anterior ethmoidal artery, and you see here the entrance to the frontal sinus. But you see also here this suprabular frontal cell, and this is very important to remove this frontal suprabular frontal cells, because inside these cells you can have an inverted papilloma, and this will obstruct also your drainage. And you see I use the curved curette, and then I remove step by step this cell to enlarge my drainage of the frontal sinus. You will see it here nicely. Okay, and you see the seal. You hear very nicely. And then if you go inside again, you see that the anterior ethmoidal artery is here not covered by bone. This is the best example. If you do work here in the anterior ethmoidal roof, be careful. Do it only under endoscopic control, because there is a risk to damage the anterior ethmoidal artery and to have bleeding. And sometimes if you damage the anterior ethmoidal artery near to the orbital wall, this artery can retract into the orbit, and you can have also an orbital hematoma. You see very nicely the type 2B from the medial orbital wall up to the middle turbinate. Here the medial orbital wall, the periorbit, and here the orbit, the frontal sinus drainage, and again the anterior ethmoidal artery. Here you see the CT, and you see the drainage many years after, of course. And don't forget that you will have a narrowing of your drainage. If you, there are many studies how is the percentage of the narrowing, but think about you have to follow these patients, and if there is a narrowing, you have to make local procedures with corticosteroids, with a balloon, and etc. In the type 3 drainage, which is the indication for a type 3 procedure, in my hands, the majority of the cases are cases with a revision surgery, with polyposis, or patients that have some triad predisposing factors, ciliary motility, Cartagena syndrome. And of course, through this wide approach, you can approach also mucosils in the lateral aspect. You can remove osteoma, inverted papilloma, and think also, and never forget that this is the last resort prior to external frontal sinus surgery. And if we are talking about the type 3 drainage or a modified Lothrop, then there are two ways. We can go from back to front. That means identify the natural ostia of the frontal sinus and then enlarge it, or we can go from front to back. I think what I'm doing, I'm going from back to front. That means I'm following the natural ostium. I enlarge this natural ostium, and then I remove the perpendicular plate. And what of the septum, and of course in the frontal septum. And what I routinely do is I make a maxilla flap here in the area of the axilla of the middle turbinate, because this flap will cover my lateral aspect here of my drainage and will reduce the risk of the circumferential stenosis. And then I have performed here step by step type 3 drainage. You see it here nicely. I have removed the pathology, and then I'm going to the other side. I do also an axillar flap, remove here also the floor, performing a type 2B, and then I elevate here in the perpendicular plate, the mucosa on both sides, because with this mucosa, I try to cover the posterior part or a part of the posterior part of my drainage. I remove here the cartilage, and this is the situation on the end. You see, a type 2B here, a type 2B on the other side. This is the frontal T. That means they remain, the horizontal part of this T is they remain part of the frontal sinus floor. The vertical is the remain part of the perpendicular plate. And you see here the first filum olfactorium. And then I remove the interfrontal, they remain in the frontal septum. And I remove also here the bone in the anterior aspect of my drainage. And you can go here up to the skin. You can palpate with your finger and feel the vibrations of your burr and enlarge step by step your drainage. And here you see the final result nicely, because you have to think that you will have a scarring and a narrowing of your drainage. Therefore, try to establish as large as possible a very wide opening of your frontal sinus. Of course, through this approach, you can remove benign tumors, as you see here, these osteomas. You can close this meningocele, post-traumatic meningocele look. This is in the lateral aspect of the posterior, your posterior wall of the frontal sinus. You perform a type 3, type 2B first, then you enlarge it in a type 3, and then you are able to approach here in the lateral aspect of your frontal sinus. This meningocele, you drill a little bit more the bone in the lateral aspect, and then I have used here a fat tissue and a mucoperiosteal graft, and I have closed this meningocele, and this is very, very easy. Then Sargicel and gel foam, and it works very nice. So think about that a large or a type 3 drainage gives you the opportunity to approach the lateral aspect of your frontal sinus endonasally. And this is also very helpful in different pathologies. You see here the MRI scan of this young boy 2.5 years later. Think also about that the type 3 drainage is the key for an adequate anterior exposure of the anterior frontal of the anterior skull base, especially here in this olfactory neuroblastoma. We have established the type 3 drainage, and that gives you enough place to resect the dura, the folks, and then to perform an duroplasty. You see it here very nice. Here is the opening of the type 3, and with here exactly you see it very nicely. And without the type 3 drainage, you cannot approach this anterior aspect of the anterior skull base. You see the MRI here after the duroplasty and tumor removal. Are there limiting factors for a draft type 3? Of course, the expertise of the surgeon is very important, but there are also anatomical factors very important, and narrow antero-posterior dimension, less than 1.5, less than 1 centimeter. It makes it difficult to bring inside the curved burr, and the risk is higher to damage the skull base and the dura, resulting in a CSF leak. Of course, poorly pneumatized frontal sinus or an hourglass configuration. Look, this frontal sinus, stenotic area here between the ostium and the lateral aspect. This is difficult. Such a case is difficult to manage only with type 3. Of course, you can remove this bone and try to approach this, but it is more difficult, and it needs an experienced surgeon to solve this problem. Of course, significant neosteogenesis and specialized instruments are also, especially for frontal sinus surgery, are also very important. Another important thing is narrowing and scarring after a type 3 drainage. If you go to the literature, you will find a lot of different flaps, a lot of different techniques, free mucosal grafts. What I'm doing, as I showed you before, is I try to cover this area. You see here the scarring in the lateral aspect of my drainage with this flap from the aganasi and axilla area of the middle turbinate. And the other thing what we are doing is we are using in selected cases mitomycin. We have published also 2 papers, and it works very nice. I will give you an example. This is a terrible case with many operations before, granulation, stenosis, and here in this case we have used a balloon to widen a little bit here the stenotic drainage here, and then we put inside a marrow cell, a small marrow cell, and we irrigate this marrow cell with mitomycin. And after many therapies, this was after 2.5 years, the result, you see we have a partial drainage of the frontal sinus. So think about mitomycin. It works not in all cases, but in cases with very extensive granulomas and very extensive granulomatosis in the drainage, then it's very helpful to use also mitomycin. So is there a place for external surgery in the frontal sinus pathologies? Look, this aspergilloma, you see this patient has no pathology in the other sinuses and frontal sinus except this aspergilloma here in the lateral axis, in the lateral recess, extending, destroying here the frontal sinus floor and extending into the orbit. And here there is a place in my hands for an above and below approach for a mini trephination because there is no other pathology. I think there is no indication for a type 3. Of course, you can perform a type 3, remove here the bone and approach it. But if there is no other pathology, I would like to go to perform a type 2A or B drainage here and combine it, and combine it with a mini trephination. You see it here nicely. I have done a type 2A drainage. And then navigation system is very helpful, not only for endonasal, but also for external surgery, because you can find the right place where you can make your incision and where you can approach easily the pathology, the aspergilloma. I have done it, mini trephination, cleaned here, removed here the pathology also from the orbit, and then I irrigate here my frontal sinus, and you can go endonasally, and this is the philosophy to combine from above and below and solve your problem. There is a question, where should we place the incision in the eyebrow? Think about the supratrochlear vessels and nerves, so you have to go medially, and think about also about the supraorbital vessels and nerve. In order to avoid symptoms and problems in the forehead, you have to go lateral from the supraorbital. Here in the supraorbital, you can palpate the supraorbital foramen. It's very easy. And so go lateral from the supraorbital vessels and nerve and medial from the supratrochlear. Let's talk about indications of an external approach. And here, inflammation are very, very rare. In the majority of the cases, we can manage these inflammatory diseases endonasally. But I've put it here because this is also a question of expertise of the surgeon. So if you are not able to perform and you're not experienced to perform a type 3 drainage, think also about an external approach. But the most common indications are severe fractures, inflammatory complication after alloplastic, using alloplastic materials, especially from the neurosurgeons, major benign tumors, and of course in cases that we have to reconstruct the anterior wall of the frontal sinus. If you use an external approach, please don't use such a procedure. This is an Riedel operation. This is a complete removal of the anterior frontal sinus wall of the floor. Think about an osteoplastic procedure. You know the principles, the appropriate incision. We do not shave the hairs in order to avoid a long-term stigmatization, especially in women. We wash the hairs with an iodine solution before surgery. We make pigtails, and then think also that you can place your incision here in the forehead. This provides you in a forehead crease. This provides you also excellent long-term results. You know the principles of the obliteration of the scalp flap. And I will give you an example. This is a lady, she had 7 operations before. Look, the very terrible scarring here. And this is not an adequate incision for a lady, and especially for a patient. Use a coronal incision, and you see a recurrent mucocele. And here we have to think about reconstruction also of the forehead. And I love to use Calvarian grafts. And if you use Calvarian grafts, use the parietal, as a donor side the parietal region. Avoid here the midline in order to avoid the damage of the superior sagittal sinus. Avoid the sutures and the temporal line, because here is the area where the bone becomes thinner and the diploid is thinner. So the parietal area. If you need a curved, use a horizontal ear graft from this area. If you need a more straight graft, especially for the nasal dorsum, go here to the parieto-occipital area and use a vertical graft. You can use it as a complete graft, or you can split it as a partial graft. And I will show you how we are doing this kind of surgery. Scalp flap, you know that, and then we remove the pathology. We drill out the frontal sinus, we silt the frontal sinus ostium, then we measure the defect, and we go to the parietal area, and we outline our graft with an burr, and then we use oscillating saws, and we use also osteotome, and we remove it. And you see here, this is the internal layer, the tabula interna, and the diploid veins can manage by diamond burr or by bone wax. This is not a problem. And then you see our graft, and then we are going to our defect. Years before, I have used microplates. In the last years, I use only sutures, but our patients have to wear for 6 weeks a handband. This is an area with an excellent blood supply, and I did never saw in the last years problems in this area. And in order to avoid irregularities between our graft and the adjacent anatomical structures, we are cover the area between the graft and the adjacent scalp with temporal fascia. You see here the CT, you see here the lady. So think about reconstruction, because she is so happy after cleaning the frontal sinus, after removal of the mucopurocele that she had. Here is also another case of giant osteoma of the frontal sinus with an intracranial and with an intraorbital extension. Here we have used, I have no time to show you the video, but we have used also, we have removed this osteoma in many pieces, and then we have used a complete, in this case, because the diploid was very thin, a complete graft, Calvarian graft, and we have reconstructed here this area with this graft, and then we have reconstructed the defect here in the donor side with Balakos, and you will see, and we can discuss it. You see here the reconstruction in the CT, you see the reconstruction here in the 3D, and here the CT scan and the MRI scan. This is the gentleman. 2 years later, you see how nicely we have removed the osteoma, and the aesthetic appearance is also very nice. Only one sentence about the osteomyelitis. First, we have to remove the contaminated bone, and then we have to treat the patients with antibiotics, and then you can reconstruct it. Here, this was many years before. Here I have used the microplates. And also, if you have such a case separated from the neurosurgeons after a fracture, you very often see if this implant has a contact with a frontal sinus mucosa, then there is a high risk of infection, fistula. Here you have to remove here the implant, drill out the mucosa of the frontal sinus, seal the frontal sinus osteum, and then reconstruct with calvarial grafts. And here, if you use calvarial grafts, this is an excellent material. You don't need a second incision. It's in the same operative field, and you can use it in contaminated spaces. This is very important. Under irradiated skin, it works very nice. And in cases with foreign body reactions against alloplastic material. And if you would like to read a little bit more, we have published our experience in 16 cases in the Rhinology last year. I think my talk was 30 minutes as I promised, and I would like to thank you, and I would like to invite you to the next meeting in Thessaloniki. And I promise you a very attractive scientific and also social program, and I'm waiting for you. And thank you again, all of you, for the opportunity to bring in this family. Thank you again to have the opportunity to give this talk.
Thank you, Jannis, for your presentation, which brilliantly summarized in a short period of time, 30 minutes, all the information needed for all different approaches for the frontal sinus, which is basically the topic of today, and we are not going to have other discussion instead of that. As always, at the end of each topic, we will go ahead with the questions. So I would go strictly to that, but after one thing, please do remind that the ERS meeting of 2020, as every meeting of the ERS, will also consist of the ERS junior meeting, which is basically...
Of course. And the juniors will have, we have an excellent collaboration, and therefore I would like to thank you, Pavel, and all the team. And you will have a strong participation in the symposia. You will have a strong participation in the instructional courses, and you will have a separate room from the 8 rooms for nearly all the days for the whole meeting. I think this is the best that we can do for you. And of course, we will do also in the end, in the afternoon sessions, we will have also a session, Meet the Experts, where 20 young doctors, the young rhinologists can meet an expert. They will prepare the questions, and they will bring the expert under pressure, you know, with many questions.
And as usual, our association will provide this time 2 grants for juniors. So let's go ahead directly for the questions. The first question is coming from Russia, and our colleagues is asking, can you explain us your postoperative care of the calvarial graft?
The postoperative care is you have to follow your patient. You have to follow and see the forehead where you have reconstructed the anterior wall. We are giving antibiotics for nearly 1 week. And then we are performing after 4 weeks the first CT to evaluate the situation. And it works very nice, but there are basic principles. You have to suture the gallia periost flap that you dissect. First you dissect the scalp flap, and then you dissect the gallia periost flap. And in the end, over your graft, you have to suture the gallia periost graft. This is very flap. This is very important because all the blood supply is coming from the gallia periostal flap. And the other thing is, what we are doing is our patients wear a headband, okay? because we do not use microplates many years in the last years. And this is what we are doing, and we see our patients every 10 days. So antibiotics is the first, advent is another, and we are following our patients every 10 days.
Perfect. Second question coming from France. Are you using post-operative medication with a squeeze bottle or with the steroids or nasal spray?
Post-operatively, we use a saline solution. We give a saline solution. The patient has to clean the nose and, of course, all the operated area. And then we are removing the crusts. There makes not sense to give a corticosteroid the first 2-3 weeks because we have crusts. We have a lot of debris and everything inside. So we have to clean the nose. We are starting giving corticosteroids after 2-3 weeks. Of course, it depends of the pathology and if the patient has predisposing factors. In severe cases, we give also corticosteroids peros, and we try to start as fast as possible also with local corticosteroids. But routinely, we start with local corticosteroids after 2-3 weeks.
Other question is coming from Florida, and the colleague is asking, are you prescribing antibiotic prophylaxis or you prescribing antibiotic after surgery in draft procedures?
We do not give antibiotics if there is not reason for it. If there is no pus or if there is not a severe inflammatory disease, we are only because the drainage of the frontal sinus is established. So we clean the situation and there is no need to give antibiotics. We give only antibiotics if there is periostitis and purulent frontal sinusitis with involvement of the orbit, of the bone, or in complicated cases.
Another question is coming from South Africa, and the colleague is asking, are you performing a dissection also of the lamina papyracea in cases of mucocele that are reaching in a superior portion of the frontal sinus?
Yes, you can do that. If it's in the superior portion, you can remove a part of the lamina papyracea in the anterior part. And it depends if it's approachable. If you after your frontal sinus drainage, if it's possible to approach in the superior part, you can do that, and it works nicely. But if not, you can make a small mini trephination. This is the alternative. But what I emphasized is if I have no other pathology and I have only a mucocele in the lateral aspect or superior aspect, it's not necessary in all the cases to do routinely a complete removal of the medial orbital wall and press then the orbit to approach a lateral isolated pathology. You know, because we have evaluated the mucoceles of the frontal sinus, and we found in 60% the mucocele was after an eyebrow incision, a Lynch procedure, and after complete removal of the medial wall of the orbit of the lamina papyracea and the medial part of the frontal sinus floor. You know, therefore, think also about that because there is a scarring, there is a prolapse of the orbit into your drainage. So I would like to say I do it only in selected cases. I try, if I can manage it endonasally without complete removal of this pathology if it's an isolated. If not, then I do a mini trephination because the functional result and the aesthetic results after a mini trephination, it's very nice. It's perfect. The aesthetic appearance, you cannot see an aesthetic problem, and the functional is also very good.
Another question from Indonesia, and the colleague is asking, what are the indication for a draft 3 procedures in chronic rhinosinusitis?
In chronic rhinosinusitis, the indication is if a type 2B drainage is not enough, if you have a scarring and if you have a relapse of the disease, a recurrence of the disease, and if you have a chronic polypoid rhinosinusitis with involvement of the frontal sinus, and if you have predisposing factors, as I said, Samter triad, and you have a mucociliary bad function of the mucociliary clearance, and if you have a patient with cystic fibrosis, then I go for a type 3 also in my first operation, because we see a lot of problems postoperatively, and you have to think, especially in children, if there is a stenotic area and if there is not enough place, you can also postoperatively not clean good enough this area. You need a lot of space.
Other question is coming from Japan. The colleague is asking, is a previous rhinoplasty a contraindication for a draft 3 procedures?
For a routine rhinoplasty, it's not a contraindication to do a type 3, but it was if patient has a trauma and the area of the rhinion and of the nasal bones is reconstructed. Especially I had such a case with calvarial grafts or with other materials from the iliac crest and etc. Then you have to be careful. You need a CT, an exact CT preoperatively because the area is unstable, and you have to think about the stability in this area. But in a routine rhinoplasty, this is not a contraindication for a type 3. I also perform cases that have chronic frontal sinusitis, and they would like to have also rhinoplasty. I do it in the same operation. There is no contraindication if there is no purulent and not an extensive and inflammation and no complications, that I do it in the same operation.
Another question from Romania, and the colleague is asking, are you using a probular technique for approaching the frontal sinus, or you open the ethmoid first and then you go for the frontal?
Again, what was the question?
The colleague is asking if you're using the probular technique for approaching the frontal sinus, or you open the ethmoid and then you go in the frontal.
No, as I demonstrate, I perform a complete ethmoidectomy, and I go from posterior to anterior and open my bulla, go to the frontal recess, and then try to identify also the anterior ethmoidal artery, and then you have landmarks. You have the skull base, the ethmoidal roof. You have laterally, you have the medial orbital wall. You have your middle turbinate, and then you go between these landmarks and try anteriorly to identify your ostium and then to enlarge your ostium.
Perfect. So we are just in time. Unfortunately, I cannot proceed with other questions, but please do remind that for any kind of question, Professor Jannis Constantinidis is available. So send him a personal email, and I think that he would like to, will be more than pleasure to reply to all of the questions. Thank you again, Jannis, for being with us today. And I hope to see you soon. And once again, I do remind to all the rhinologists, allergologists, and neurosurgeon, ophthalmologists to attend the ERS 2020 meeting, because the application is already open. Reserve your seats, and I see you for the upcoming ground round, which is going to be planned for the 1st of December. This time we are going to have from Dubai, Dr. Islam Herzallah, who is going to talk about endoscopic DCR. Thank you again, Jannis, for being with us, and I hope that you will have a great...
Thank you so much, and stay the way you are. You do a great job bringing all the members from different countries together. Thank you so much.
Thank you again. I'll see you. Goodbye.
Bye-bye.